let me bring up one of the most surprising and shocking problems that I've seen of late, not of late, over the past few years, hand washing or lack thereof. People aren't washing their hands. Visitors need to wash their hands. Physicians need to wash their hands. And another problem that I've seen, you need to fill me in on this, is the use of the alcohol-based cleaners, those Purell-like compounds, instead of hand washing, and they don't kill the spores at all. How do you bring hand washing back?
That is a challenge that I think all of us have in infection control, because the use of alcohol hand hygiene has really replaced hand washing in many cases, and we always recommend that if you have visible soiling that you wash your hands. And I think in our hospital, at least, when we have an isolated patient with C. diff, we automatically require people to wash their hands after leaving that room. That is not a universally recommended practice, however, and Erik knows that well. It is a practice that is reserved for high rates of C. diff, but we do it all the time in our hospital, and I think it's appropriate. We don't know for sure what the best hand hygiene is after leaving a room of a patient with C. diff, if you've been wearing gloves. Because you probably don't contaminate your hands all that much.
I think the first step is actually you need to don and doff your personal protective equipment properly, the gloves and the gowns. You know, that's our first step. If you never contaminate your hands in the first place, it doesn't matter if you use alcohol or not. And so, you know, and you also need to remember, C. diff is all over these rooms. So if you're going to walk in that room, you need to wear those gloves. In one study, they showed that a healthcare worker's hands were just as likely to be contaminated with C. diff, whether or not they ever touched the patient after leaving the room.
The keyboards, the surfaces.
C. diff is all over that room.
You know,
so put on the gowns and gloves, and then remove them properly, because we've been doing some studies lately as well that shows there's lots of self-contamination. And in removing PPE, you know, the gloves and gowns, we find that 25 to 35% of the time, healthcare workers are contaminating themselves.
And it's important also to remember that it's also how do you wash your hands and who should wash their hands. It's not just healthcare providers, but it's also the patient. And it's also family of the patient, because those are used as the vehicles. Even if they don't get sick, you know, C. diff does not jump from one patient to the other, and patients usually don't interact within hospitals, but it goes through the hands of whoever. And when you wash your hands, it's important to remember that you really have to do it for a period of 30 seconds and physically wash your hands, because it's not the detergent or the water, it's the physical activity.
Are you sure that C. difficile doesn't jump from patient to patient?
Doesn't have legs? Does it have wings?
I think it's vaporized.
Oh, okay.
And I think it does.
Okay, but I'm reminded in a very fundamental sense of that book that everything I needed to know in life I learned in kindergarten. And one of those things is wash your hands, at least before you eat. Wash your hands. Anybody disagree with washing your hands? I think with that, we're going to move on. This has been a terrific discussion. And before we end this discussion, what I'd like to get is some final thoughts from each of our panelists. So this is your one moment to talk to our audience without being interrupted for a few seconds. Dr. Brandt, why don't you start us off?
The points that, first, thank you for inviting me. I enjoyed this and I learned a lot. But the points that I would make are to re-emphasize the importance of antibiotic stewardship, to emphasize how important it is to be aware of C. difficile and how common it is, and to think of it whenever you have any patient who has diarrhea, and especially as gastroenterologists, you have patients with ulcerative colitis who come in for a flare, what appears to be a flare of disease. Test that patient for C. difficile. And when we manage our patients with C. difficile, as a gastroenterologist, talk to your ID colleagues.
Dr. Dubberke?
Yeah, so I definitely agree with the comment on antimicrobial stewardship. Definitely, as Yoav mentioned, 30 to 50% of people on antibiotics don't even need that antibiotic, and that's pretty low-hanging fruit for being able to prevent C. diff infection. And another thing I think to stress is to remember when that patient does develop C. diff infection, educate them about it. Let them know there's a good chance it might come back, and if the diarrhea starts to come back, they should give a call. And something we haven't touched on yet, but part of my education, especially those patients with recurrent C. diff, I actually recommend that they use a bleach-based cleaner, not only in their bathroom, but also in their kitchen. Because these patients with C. diff, when they go home, they contaminate their home with that strain of C. diff they left the hospital with.
Dr. Freedberg.
So C. diff is the archetypal disease of the gastrointestinal microbiome. It's caused by a single organism, and it's cured by replacing a damaged microbiome with a normal one. Right now, we treat C. diff with antibiotics, but the future, I think the near future, will be treating C. diff with some kind of targeted therapy, although we're not quite there yet. Community physicians should know how to diagnose and treat C. diff, and then they should be a part of antibiotic stewardship for C. diff. C. diff is a reason not to prescribe antibiotics to patients. So in that sense, perhaps it's the silver lining on the cloud. You can explain this to patients, and some at least will understand why you're not prescribing antibiotics in situations where they're not necessary.
Dr. Gerding.
Just a couple of comments. One general one. I think the state of fecal microbiome transplant is still in its infancy. It is not an approved therapy, and I would suggest that if you're interested in doing FMT, that you enter your patients into randomized controlled trials. We're starting to learn a great deal about comparative treatments versus FMT, and I think there's just a huge amount to learn. The other thing that we've talked about is all the things you shouldn't do in antimicrobial stewardship, and leaving you with no recommendation about what you should do for patients who need an antibiotic in the ambulatory setting. And there's pretty good evidence that tetracyclines, doxycycline, monocycline, are probably protective against C. diff in this ambulatory setting. So I would suggest using more of those drugs. They're inexpensive, they're very effective. And another alternative that also is low risk is to use trimethoprim sulfa, Bactrim or Septra in those settings. So that would be my suggestion if you're practicing good antimicrobial stewardship.
And with the last word, Dr. Golan.
Well, I don't have too much to add. Just for our community care providers, I think what really is important is to remember that C. diff is not a rare disease anymore. And if you have a patient who was recently exposed to antibiotics or on antibiotics and develops diarrhea and really becomes sick and have bad diarrhea, think about C. diff, test for C. diff in those patients. If the patient feels fine, even if they have new diarrhea, you don't necessarily have to test them for that. And that will be my comment.
Well, I want to thank all of you for being here. This has been a tremendous discussion, actually. It's a terrible disease. My sense is it's getting worse, and there are some new therapies on the horizon. So it's encouraging, but at the same time, we have to be careful. That's my takeaway from what I heard from all of you. I want to thank you for watching. I'm Dr. Peter Salgo, and I'll see you next time.